Hey everyone, and welcome to another video for Module 1. Since we're talking about patient assessment, I wanted to try to briefly go over some electrolyte information with you guys, mainly the clinical manifestations of hypo and hyper states. Hopefully you don't get hyper confused, but I'll try to make this brief. I'm very sorry about that. I'll try to make this as quick as possible. So just bear with me through this, and hopefully you can take something away and apply it to your bedside assessment. All right, so today we're going to be talking about sodium, not all the electrolytes, some of them. Sodium, potassium, calcium, and mag. Okay, so these are our suspects for today. What you're going to notice with both increases and decreases in the serum concentration of these electrolytes is that they share some same signs and symptoms or clinical manifestations. So just be aware of that. You'll see a lot of nausea, vomiting symptoms, and things like that. And I will use abbreviations. Also, I want to go over some units really quick. Sodium, potassium, and magnesium. Let's go over here. They will be expressed in milliequivalents per liter. And for this course, that's how I'm going to express the normal values. Calcium is expressed in milligrams per deciliter, okay? The reason I say this is because your book has a bunch of different units for these electrolytes. I like to keep them all the same, and you should really be measuring electrolytes in milliequivalents, okay? All right, with that said, let's jump into it. All right, so let's talk about sodium first. So sodium is the most abundant extracellular electrolyte, okay? We measure about 135 to 145 milliequivalents per liter, okay? So it's the highest concentration outside the cell. With that being said, there's a lot of effects in tonicity and osmolarity that sodium has, and a lot of the manifestations of disorders with sodium concentrations are from tonicity issues. So we're going to start off with hyponatremia, so low sodium first, okay? My stylus isn't keeping up with me today. I think I'm wearing it out. All right, we're going to start writing in white so you can see this. So we're going to classify this as levels less than 135, okay? So hyponatremia, generally your patient's going to present with weakness. They're going to be tired. They might have some muscle cramping. Okay, they might be stuporous. Nausea, vomiting might be some symptoms or signs that their sodium's low, but like I said, it's not very specific. And finally, the book, in Respiratory Care book, they state that the patient might be giddy. So I thought that was interesting. I've never heard that before. So giddiness is a clinical manifestation of hyponatremia. All right, so hyponatremia very quickly can be classified in 3 different ways. This is why it deserves a video of itself. But briefly, hyponatremia can be hypovolemic, okay, euvolemic, and hypervolemic, okay? Those are different states of total body water that can affect serum sodium concentrations, all right? So just remember, your patient's gonna have an altered mental status. Also, let's just do a quick diagram. So let's say we have a cell here. We don't have much on the inside, so not that many solutes, and we have a lot of solutes on the outside of the cell, okay? So that would be hypernatremia, which we're going to talk about in a second. Hyponatremia, there's not a lot outside the cell, okay? And there's a bunch, or the normal amount, let's say the normal amount inside the cell. So what's going to happen is water is going to follow the concentration gradient. So water is going to want to flow inside the cell in hyponatremia, okay? And this will cause the cell to get bigger and maybe die. In hypernatremia, water is going to want to flow out of the cell, okay, to relieve that concentration gradient. So, or to reestablish normal osmolality. So here, the cell, it will shrink and it could die. All right. So just think about plasma volume when all this stuff rushes in and out of the cell, and what it could do to your brain. So altered mental status, cerebral edema, encephalopathy are all signs of sodium derangements. So mental status. Okay. I'm going to leave this here for also hypernatremia. It's very similar signs and symptoms. We'll define hypernatremia as of serum concentration greater than 145, okay? And this would represent a hypernatremic state. This would represent a hyponatremic state, okay? This can be caused by loop diuretics and diarrhea, sweating, high sodium intake, things like that. These patients right here who are hyponatremic, they might crave salt, okay? You'll see that on some exams. It's pretty simple. And these ones will be very thirsty. All right, so that's it in a nutshell. They'll have a severely or oftentimes altered mental status and muscle cramping, but definitely encephalopathy and things like that are things to be aware of with hyper and hyponatremia, especially while correcting it. All right, let's get into potassium. So I usually like to do potassium anytime I talk about it in brown, because potassium and poop seem to go together quite often in critical care, but I don't have brown, lucky for you guys. So normal serum values we're going to use here are 3.5 to 5.0 milliequivalents per liter, okay? So, we have hypo and hyperkalemic states. Let's split it down the middle here. Let's get this back in white. So let's do hypo. This arrow here is going to indicate hypokalemia. So things we'll see in hypokalemia, again, muscle weakness. So we're going to say weak. All right, fatigue, diffuse pain, myalgias. Okay, malaise, just general sick feeling. And also decreased gastric motility. So you might have an ileus or something like that going on, not GS. Gastric motility, constipation, ileus, things like that, okay? Your ECG changes. So with hypokalemia, always think U wave, all right? U wave. You will also, or you could potentially see inverted T waves. Invert T or no T wave, okay? You'll also see QT prolongation. All right, so these are some objective data you can get, some subjective statements here, which you can observe as well. So that's what you'll see in hyponatremia or kalemia. Hyperkalemia is something we often see in the ICU, and I mean this could be due to renal insufficiency, and acidosis, a lot of issues that are going on there. So we can get into that in another video later on the semester, but just for now we're talking about assessment and clinical manifestation. So the patient might have increased deep tendon reflexes, so hyperreflexia. I apologize, my notes had me wrong here. It would be the opposite. Because we have too much potassium on the outside, it messes with our depolarization. Okay, decrease. Muscle weakness, again, which seems to be a running trend, right? All right. We can also have paralysis, but most of the times death would probably occur before paralysis. You might need dialysis if you have too much hyperkalemia. All right. But that is something that you might observe as well in very hyperkalemic states. All right, let's get to the ECG. So ECG changes, a lot of the literature states that a concentration greater than 6 milliequivalents is when you would start seeing peak T waves, okay? So when you're doing your assessment and you see these peak T waves, you could possibly assume that their serum concentration is greater than 6. Later on, in more severe states, and a lot of literature states greater than or equal to 14, which is, it could happen at 12 or 13 or whatever, you'll see VFib or a sinusoidal, non-pulsatile, or non-life-sustaining ventricular tachycardia, okay? So that's what you will see. Okay, so keep an eye on that with your kidney patients, which are a lot of your ICU patients with RTA or just general end-stage renal disease and things like that. All right, that's potassium really quickly. Let's move on to, what was next? Calcium. So calcium I'm going to do in white because, bones and stuff. All right, so calcium. So calcium is another cation that is a commonly measured electrolyte, and it's measured at normal values. We're going to say 8.5 to 10.5 for our lecture, because some literature states like 8.6 to 10. I mean, I don't know. I think that's just a little too much for what we're doing right now. So, and that's in milligrams per deciliter. Okay. So that's an acceptable range for my examinations or whatever it may be. I'd probably give you an example that was like way off, so you wouldn't have to really remember such a tight constraint. All right, moving on. Let's split it up like we've been doing, okay? So we got hypo over here and hyper, okay? Clinical manifestations, okay? Not really causes per se. We're just talking about clinical manifestations of these disorders. So hypo, hyper. Hypocalcemia, what do we have? The patient might appear malnourished. Okay. And these will be like your alcoholics and things like that. They'll be malnourished. They'll have a calcium deficit. They'll also have other issues going on like pancreatitis and things like that. Renal dysfunction will be evident. They might have some tingling, diffuse tingling. Okay. That could potentially lead to tetany, which wouldn't be fun. All right, so if you see that during your assessment, you might think about low calcium levels. Yeah, and just general like muscle weakness and cramping, and obviously tetany, so rigidness. All right, let's see here. So there's really nothing I can really add there. Let's get rid of this. My notes here kind of go along with what happens, what can cause this, and there's a lot of very interesting things that can cause this. But a lot of the sensation you'll get that we're going to talk about for our clinical manifestations are with like feeling and muscle sensation and things like that. As we all know, calcium actually plays a big role in cardiomyocyte function and contractility and things like that. So we'll get into that in a little bit later. But here you also might have some perioral numbness, okay? So all that sensation or lack of sensation. So numbness around the mouth, that might manifest as low calcium levels in the serum for your patient. What I was going to say actually was there's certain syndromes like tumor lysis syndrome, massive transfusions that can cause low calcium levels. All right, that's kind of what I want to talk about when I was stumbling up here. This you'll see a lot in your medical ICU. This you'll see a lot in your SICU, your surgical trauma units and things like that. And we'll get into the pathophysiology of these things later. Increases in calcium, serum calcium. So you'll see your patient might have anorexia, might be anorexic. All right, so we're talking about intake at this point. They might have nausea, vomiting. Okay, they might be polyuric, obtunded. They might be confused, so altered mental status. And also, their ECG could show a shortened QT interval. Short QT interval. There we go. Okay? So that's calcium in a nutshell. Hypocalcemia, hypercalcemia. Some of the things you might witness on assessment. Okay? Let's move on to magnesium. We're almost done here. So magnesium is an interesting electrolyte, at least to me. we're going to refer to the normal values of 1.4 to 2.0 milliequivalents per liter. All right. So with magnesium, kind of like calcium, much of it is inside of the cell versus outside of the cell. I believe like 1% is extracellular and the rest is intracellular. I don't believe we talked about that with potassium in this video, but potassium is about 98% in the cell and 2% outside the cell. Some texts say 90%, but you get the point. There's more in the cell than out of the cell. So low MAG levels, okay, and we can assume most of the time that a lot of patients in the ICU have low MAG levels, be it because they're on diuretics, they have renal issues or anything like that, but about 65% of ICU patients have low MAG levels, okay? So you'll often see them treated with magnesium. And also, if they can pee it out, you're usually fine. And you need to give a lot of MAG to actually replace anything because a lot of it's inside the cell. Remember that. So what you'll see is you'll see R, tremors. Okay? You'll also have some increased DTR, deep tendon reflexes. You'll have some ataxia. You remember these terms? If you don't, please let me know, or just look them up. Pretty easy. Your patient might present with convulsions. Hypertension. So a lot of preeclamptic people. So preeclampsia, sometimes they're treated with MAG because they are so hypertensive. So low levels of MAG, hypertension, think of it that way. And then, of course, death, which is usually the end-all be-all of these horrible imbalances in the most extreme sense. So the one main clinical sign, objective sign that you will see that you've probably heard many times before is this rhythm right here, the big old squiggly line. So that's torsades. So torsades happens often with low MAG levels, and that's usually because magnesium deficiency coincides with potassium deficiency, also calcium deficiency, and phosphate. So all those electrolytes kind of go together, and that can really mess up your heart. So you get these polymorphic ventricular tachyarrhythmias, and they're treated with mag sulfate, remember? MgSO4. And it's given IV, and that's usually that's always how mag is given IV, with mag sulfate. So mag sulfate can be, or magnesium administration can be almost an antiarrhythmic agent. But remember, torsades equals low MAG, okay? Give MAG. So that's how your patient might present. So let's go to hypermagnesemia. It's very hard to say, hypermagnesemia. Increased levels of magnesium in the serum. So we're going to say greater than 2, okay? And so this is rare. Okay, you won't see this very often. You'll see it in renal insufficiency, just like everything else. All right, the kidneys can't get rid of it or they can't keep it in. Also, you'll see it in malignancy, so cancer. We'll say CA for cancer. These two scenarios can increase your magnesium concentration, but it is rare. With that said, you'll basically experience the opposite of hypomagnesemia. So you'll have decreased DTR. You'll also have hypotension, so decreased blood pressure. You'll also have some bradycardia, decreased heart rate, not R, heart rate, HR, okay? And coma and death can result as far as mental status changes, all right? Okay, so an interesting point about hypermagnesemia that I'm going to make before I end this is that hemolysis can cause this, just like it can cause an increase in K, because it's kind of the same in the same area, hemolysis. So if you're on ECMO or something like that, and there's a lot of hemolysis going on with the pump, your RPMs are very high, whatever else is going on, you could see an increase in MAG. But just for some perspective, 250 mLs of red blood cells has to lyse to give an increase of 0.1 in your MAG concentration. Okay, so you would go from 2.0 to 2.1 if you lysed about a unit of blood. Okay, so that's kind of rare and an extreme example. All right, I hope this helped you. I tried to make this as fast as possible and give you just the solid, gritty information. Use this with your assessment. Use it for your exams. You'll get a scenario and it'll be very clear, okay? Hang in there and thanks for watching.